Good morning, everybody, and welcome to Health Talk. I am your host, Dr. Neeru Prasad, pediatrics and emergency medicine physician affiliated with Henry Ford Health System, St. Joe, Oakland, and Bowman. The theme of our Health Talk today is the advances and role of targeted therapy in cancer. Joining us today as our guest star is Dr. Mohammad Muhsin Chisti, and he is assistant professor at Carmano and also staff at McLaren, and he is going to highlight our viewers regarding the advances in the treatment of cancer. Good morning.
Good morning, everybody. It's a great pleasure for me to be on this show. As already mentioned by Dr. Prasad, I'm a hematologist, oncologist, and I'm active in research, and also I'm staff at various institutions, including McLaren, Oakland. And I do teach at a couple of medical schools as well.
So that is very good. I was so impressed when I saw your CV. And also, whenever I have a guest speaker for particular subject, I do my own research. And now I'm so impressed how much has been done towards the targeted immune therapy for treatment of cancer. So for the sake of our viewers, the first question is, what is cancer?
Yeah, things have changed tremendously, looking at history, how this cancer treatments have been there since centuries. It's so amazing how much things have changed. So my topic today, it will be more focused on what is cancer, types of cancer, very briefly, some causes, and what the treatments were and what they are now. And then we will focus on targeted therapies today. And there's also a segment on immune therapies, which would be too much to talk about today. So we'll at some point talk about that as well.
So our viewers have to wait for another segment of your show, then we will talk about this. But right now, cancer, what are the incidence and the age group?
So cancer, basically, when we medically talk about it, it's a clone. Cancer means a clone. It all starts with a single cell going crazy and starts multiplying without breaks and forms like a clone, a mass, or what we call as in a liquid tumor, solid tumors, and so on and so forth. So basically, when we define cancer, it's just a cell going crazy, non-stop multiplication, clonal, and becoming a mass.
So this is what a cancer is, for the sake of our viewers to know. Just abnormal rapid growth of one particular bat cells in the body, right? Okay. What are the age group that you see at your office?
So I'm an adult hematologist, oncologist, so my main focus is just adult population. So the demography of cancers in children is different, and the types of cancers in children are different, and so I'll be focusing more on the adult side.
Okay. So then in the, like my background with my couple of year fellowship with hematology and oncology, I have done so much biopsy and say the cells, for the leukemia in the kids, but I don't have too much exposure to the adult. So could you tell me what are the types of cancers that you see in the adults?
So most commonly in community, the cancers that we encounter are like related to, lung, head and neck, pancreas.
Starting from head and neck.
Genitourinary cancers, especially prostate and ovarian. So it's kind of a diverse population that we see in the clinic.
Yes. Okay. And then now, what are the causes of cancer?
So it's kind of a very broad question, but to briefly explain, there are some cancers where we can link causes.
Genetics.
Exactly, but there are a lot of cancers where we don't know what happens. So some cancers, for instance, if you talk about lung and some bladder, colon, there is a link to smoking, there is a link to some environmental exposures, but there are cancers that are linked to genetics, like there would be a type of breast cancer, where there are mutations known as BRCA mutations. There will be types of colon cancers where you have mutations like Lynch syndrome and stuff like that. So it's a very diverse scenario where radiation could be having a role in as a causative agent as well.
So according what we know, that it could be immune related or it could be age related, right?
Right.
And the elderly more susceptible if they have a background of smoking or chronic irritative bowel disorders, things like that, right?
So here's the thing. So what we see as the cells age, as they become more and more sentient, there are more genetic changes that happen in the cells. That leads to mutations, that leads to driving forces like what we call the changes in the oncogenes that leads to cancer.
Okay, isn't it very interesting how you target the cells?
Correct.
Very, very interesting, yeah. So now, I sent a patient to you from my office, possibility of cancer. Suppose, let us start some simple like a breast cancer, all those. When they go to your office, by the time they reach your office, they already have ultrasound and everything.
Right.
So what do they expect once they are at your office?
So by the time a patient who has cancer already knows that why he's coming to an oncologist, so the diagnosis is already made. Or there are instances where they say like there is something, some susceptibility or suspicion of cancer, so it might be a good idea to see an oncologist. So that's when we break the bad news, what we call as breaking bad, and it comes with experience, and then you have to make the patient
like a 45-year-old lady with breast cancer. So now, will you do some extra blood work besides what a primary care physicians have done?
Yeah,
at your office?
Definitely, it depends on the type of cancer and also the workup that was already done or what needs to be done. There's a protocol that there are guidelines that we follow known as NCCN guidelines. They guide us to do the right thing for the right type of cancer and right patient.
So those guidelines are already there, whether it is a woman with breast cancer or a male with lung cancer.
Correct.
And when they go to your office, then you will do follow the same guidelines.
Correct.
Now, tell me something, the treatment between chemotherapy, radiation, and this new therapy.
Right. So now we're coming to the treatment part. So I just want to share a little bit of history. So when we talk about the cancer history, believe it or not, very, very earlier in like late 1800s, there used to be treatment like putting leeches on the skin. That's where we started. Leeches on the skin, and orange peel infusion, steel wool, and then things kept on changing. Then there are things that we discovered by serendipity. Sometimes even a world war could give us a drug known as melphalan in myeloma. So it's all like that has come slowly down the road, and a lot of experimentations, a lot of research, and finally we are here in 2016. We have very, very advanced cutting-edge technologies to encounter cancer, and one of those are the monoclonal antibodies.
Yeah. So I was reading about these monoclonal antibodies. It is such a big chapter that we won't be able to do that. But I just want you to tell our viewers about the other recent therapy. You brought some beautiful diagrams and pictures.
Right. So monoclonal antibodies, giving you background what they basically are, they are proteins. So proteins. So nature made us like we have stem cells in the bone marrow. These stem cells mature to become white cells. One of the types of white cells are known as plasma cells. So the function of these plasma cells is to make soldiers that fight infection or antibodies. These are proteins. So what we have done is we have genetically engineered cells to make these artificially, very targeted, very specific for different types of diseases, not only cancer. You have these antibodies in autoimmune disorders like lupus, like rheumatoid arthritis.
Ulcerative colitis.
Ulcerative colitis, right. So these are the monoclonal antibodies basically.
Okay, so then you will inject them and they will get themselves attached to the Plasma cells, which is malignant cells.
Right. These are drugs that are given through the veins, and they have much lesser side effects when you compare to chemotherapy. So traditionally, always cancer has been treated with chemotherapy, and chemotherapeutic agents are effective, they are good, but there is a high failure rate, and somebody cannot be on chemotherapy forever. So now you have a drug that is very focused, very targeted, goes to specific cell, just the cancer cell, where it finds its antigen, binds to that cancer cell and kills specifically that cancer cell. That's why it's a targeted therapy.
Okay, so like before, during my fellowship in hematology, with all those cytotoxic drugs, so many side effects.
Right.
The kids used to be more sick than even before, loss of hair from the radiation.
Right.
So when you inject this kind of the monoclonal antibodies, now there are oral forms also? Or
No, so when we talk about targeted therapies, we look at two things. One is the antibody segment, those are the IV or the drugs that are given through the veins. The other one are the oral pills, also known as tyrosine kinase inhibitors or mTOR inhibitors, and many other drugs like that. If we get time, we might talk about them as well. But we'll start with the antibodies. So these are on the slide you can see FDA approved.
These are what FDA
approved monoclonal antibodies. We have, it's a long list, but just for the sake of some information, we have like cetuximab, bevacizumab, alemtuzumab, and rituximab, all. So the reason they are known as MABs is MAB means monoclonal antibody. That's as simple.
I thought so too. Monoclonal antibodies, MAB. Okay. So depending upon what kind of cancer they have, you get that particular antibodies. How many injections do they need?
It all depends on different types of cancers and different types of antibodies as well. Whether you're looking for a adjuvant or an add-on therapy versus somebody who's on palliative, more like
And I was going. That was my next question. When you do this monoclonal therapy, now, do they continue to have radiation? Do they continue to have cytotoxic drug, or you stop those?
Okay, that's a good question. So here what we have done, so in the trials, like for instance, I'll quote breast cancer. So there's a type of breast cancer known as HER2 positive breast cancer, where there is this antigen HER2 on the surface expressed on the breast cancer cells. So if you have a lady who has early stage breast cancer, once she is done with the surgery, then we give chemo plus this targeted agent, and it has increased survival tremendously.
So supplemented
for the first 1 year.
Supplemented with the chemo.
And similarly, in stage 4 cancer, when we, for instance, take an example of colon cancer, if you use chemotherapy alone, survival is only like 7 to 8 months, and then you add on targeted agent, they can go on and on till they get resistant to that drug.
Oh, okay. So just for the viewers to know, once they go for this therapy, it is probably supplemented with what initially they have been getting, whether it is radiation or whether it is chemo or whether it is both. Right.
Correct. So I can share some couple of patient examples without quoting the name or anything. So there was one guy, who met me in 2011, 2010, 2011. He had metastatic lung cancer with effusion with fluid around the lungs.
Okay.
So we met him, told him in the hospital, this is stage 4 lung cancer. At the most, you might live 3 months, maybe 6 with chemotherapy, but it's worth a try. So we gave him the chemotherapy part of it, had an excellent response, was doing very well. Then we discussed this targeted agent known as cetuximab. Told him it's worth trying. These are new drugs. At that time, the trials was still kind of ongoing. He's he was okay with it, and we started it. And now, to this day, he's still alive.
That's
Stage
very
4
good.
lung cancer, 2011. It's 2016.
Stage 4 lung cancer is
Yeah,
still alive. That
right.
is
Very active lifestyle, minimal
Yeah.
side effects. The side effects he gets is rash. That
yeah.
sometimes
You know
bothers
what?
him.
We all get rash, don't we?
Yeah. Very exciting. There are lots of examples. There would be another lady with which I can share, like lady in 60s, stage 4 breast cancer, and she's on maintenance trastuzumab or Herceptin. Similar story since 2009.
So once we decide to treat them with this therapies, those IV injections, are they given like one time or every month or every? They are all dose calculated, right?
So they have all different schedules. For instance, if you take example of Herceptin, it's given every 3 weeks. If you take example of cetuximab in colon, it's given every 2 weeks, or even there are drugs that can be given weekly. So it's all different.
So depending upon the stage of the cancer, so for our viewers to know, depending upon what stage somebody is, the therapy is accordingly calculated, whether once a week or once a month or things like that, right?
Yeah. So next slide can show, on the next slide, I would show the economics, like what these monoclonal antibodies have, the impact on the economics. These are one of the most expensive drugs.
I know
in this era, and that's what is driving the pharma industry right now.
My next question, because all these things are, and how much of it Medicare covers, and that too. Yes, this is very interesting.
Yeah, this is one of the things that has increased the expenditure on the these insurance companies, and that's why it's becoming hard sometimes to treat the patients if it gets too expensive. So can you comment on
that? Such an interesting slide.
So these are the monoclonal antibodies we just were talking about, like trastuzumab. This is a monoclonal antibody used in metastatic breast and adjuvant breast cancer patients, and it has tremendously increased the survival. That's what I was quoting, the example of a lady, who is on this. Pertuzumab is another one, similar agent, we were just talking about. And then there are agents like TDM1. This is a very smart agent. So what they did, I can compare it very easily, like with a drone. So you have a bomb attached to the drone, and the drone knows where to go and where to attack. It's exactly the same thing with TDM1. So it is a monoclonal antibody, it's this V-shaped antibody, and then there's an attached chemotherapeutic agent to it. So it specifically goes to the cancer cell, attaches to the cancer cell, drops this bomb inside the cancer cell, and kills that particular cell with minimal side effects.
So is it like more for the bone cancer or
it's more for the breast.
Solid tumors.
Breast. It's just for breast right now. But there are a lot of drugs, similar drugs being developed,
for
more
osteogenic
targeted.
Sarcoma, bone metastatic tumors.
They're not there yet. No. Similarly, like CD20 targeted molecule known as rituximab. So what it does is this antibody attaches to the CD20 target on lymphoma cells. So excellent responses in lymphoma since we have developed these drugs. For instance, we used to give a chemotherapeutic regimen known as CHOP, but since rituximab came, we call it now R-CHOP, and now the patients have excellent responses. It's used in CLL or chronic lymphocytic leukemia as well. It's used also in autoimmune disorders. And I can't even imagine how we can treat lymphomas without rituximab today.
Exactly, yeah. Like before, lymphoma, isn't it radiosensitive tumor?
More chemo-sensitive than radio, so it melts away with chemotherapy. But then when you have a drug that is very targeted...
which is even better.
Right, and what we are doing these days now, for instance, in CLL, once we treat them with chemotherapy up front, then we keep them on this antibody like rituximab maintenance. And it just improves survival tremendously.
Okay, so for somebody with a myeloid leukemia, first the chemotherapy, radiation, and then this is more for the maintenance, to get rid of those
even
cells.
before, even at the start of the therapy, as well as for the maintenance down the road as well.
Could you comment on this?
Yeah, this is the one we were talking about. This is
Okay.
rituximab. This is half mouse and half human. That's
Half?
why,
Okay.
yeah, that's why we call it chimeric. Like this is derived half from the mouse
Okay.
protein and half human, genetically engineered.
Okay.
So we have other antibodies, like we can see on the next slide, which are more human. MOMABs, what we call as, that's why they are named like tuximabs are half mouse, two MOMABs are more
MOMABs.
human. So for instance, ibritumumab is another one. There are multiple. We can go on and on talking about each of them. But great drugs, and we really feel more privileged to have these drugs and doing benefit to the community way better than previous oncologists that were in 80s, 90s, and even early 2000s.
Exactly right. Yeah, this is amazing,
Yeah.
isn't it?
Right.
So now we went through all this. We don't have too much time to talk about the monoclonal antibodies, and hopefully, you have some other slide here.
Yeah, I was, other part of the segment, I wanted to talk about the tyrosine kinase inhibitors.
Yeah, okay.
So tyrosine kinase inhibitors are another type of targeted agents. They are oral pills.
Okay.
So it all started with a drug known as imatinib, which revolutionized the treatment of chronic myeloid leukemia.
Okay.
So since 2002, 2003, CML, or chronic myeloid leukemia, has really became like hypertension or diabetes, or the disease that could be easily treated with oral pills. And we have similar pill known as Bruton kinase inhibitor for CLL, known as ibrutinib. Very effective, very, amazing treatments. Now, even CLL patients down the road from a year or so, you would see they are just on pills. They don't need chemo anymore.
Yeah, which is good for them.
Similarly,
if they are right on the pills, they can just take a pill.
Correct. Similarly, in lung, we have a drug known as Tarceva. And there's another drug known as crizotinib. I can share another example. Like I had a very young patient, in 26-year-old. He had just came from I think Iraq or somewhere. After finishing his army duties, he developed lung cancer. Very interestingly, and he's young. He's a non-smoker, engineer by profession, doing excellent work. It was pretty shocking. So I'm talking about 2010, 2011. So at that time, we sent his tissue for special testing, known as ELK gene rearrangement.
ELK gene?
ELK gene rearrangement. So this is a special mutation that is seen in very few, like 5 to 7% of the lung cancers.
Okay.
So he tested positive. Never got chemotherapy. Was started on this pill. He's back in his own life. He works as an engineer. I cannot, disclose more, but he's married and doing very well.
Isn't it great? Yeah, that.
So it's 6 years now, and he's still living his dream and doing very well.
So much advances in the medicine. Every single field of medicine, we are getting. And now, just the last question. I want to ask you about this cost. Does Medicare or insurance accept part of these treatments, or patient have to be on their own?
So it all depends on what type of insurance people choose. That's what I have learned. It's very hard for us, sometimes even heartbreaking to see. There are people without insurance. We want to help them.
But
we look for the trials for them.
Because they are so expensive.
Right. You can imagine a drug, a targeted agent can cost between $3,000 a month to anywhere between $90,000 a month.
Is that so?
There is a drug known as nelarabine, which is pretty expensive. There are which is used in ALL. So there are, it's a wide variety of, drugs with wide, price range.
That is something that we have to talk about, that the insurance people are worried about. I think
exactly.
It should be a burning topic for them, right?
Exactly. There's
how they can.
I remember a single dose of one ALL patient costed insurance roughly around $60,000. One dose.
Oh my God! So now, just to wrap up the whole thing, give your advice to our viewers?
The advice, I would say, things have changed tremendously in cancer. First and foremostly, whenever somebody gets diagnosed with cancer, it is heartbreaking news.
It is, yes.
But there is a lot to offer. There are targeted agents, there are immune agents, there are drugs that did not exist even a year or two before that show excellent promises, and also sometimes cancer going into remission for a long, long time.
Yeah, so for our viewers to know, even though somebody is suffering from something like this, there's always treatment available, and down the road more and more research are being done. So just think positive and take care of health, right? As
Correct.
much.
And also, last but not least, we should always think about clinical trials.
Clinical
Somebody did
trials,
those
right,
trials
yes.
before. That's why we have these new drugs.
this,
And it's
yes.
our duty sometimes to look forward, to look for new drugs that will benefit humanity in future.
That is true. So thank you so much for coming to my show. I'd like to thank our viewers, our producers, camera crews, and for helping me prepare this particular tape. And I'd like to thank you, Dr. Mohammad Muhsin Chisti, who is assistant professor at Karmano at McLaren. And anybody wants to contact him, they can easily call the McLaren Hospital for referral. Thank you.
Thank you. My
again.
pleasure and
yes,
honor.
and have
Thank
a
you.
wonderful
You too. Thank
day.
you.